All right, I'll go ahead and get started while we're getting some people in the room. Good afternoon and welcome to today's webinar, Prevention and Containment of Candida auris in Hemodialysis Settings, brought to you by Quality Insights ESRD Network 3. My name is Grayson Kist and I'm a Digital Communication Specialist with Quality Insights. Everyone has entered the meeting on mute. If you have questions or comments, please submit them either using the chat or the Q&A tool in your Zoom menu. If time allows, we may answer them after the presentation today. And now I'm going to introduce our guests. Adrian Sherman is an HAI-AR epidemiologist in the Infection Control, Healthcare, and Environmental Epidemiology program at the New Jersey Department of Health Communicable Disease Service. Adrian serves as a subject matter expert on healthcare-associated infections and antimicrobial resistance epidemiology for NJDOH. Naomi Carbone is a registered nurse and has worked in the dialysis field for over 20 years. She holds a board certification in infection prevention and control and works for DaVita Healthcare as an infection preventionist. Jessica Arias is the Infection Control Assessment Response Unit Lead with the New Jersey Department of Health Communicable Disease Service. She is board certified in infection prevention and control and is recognized as a fellow of the Association for Professionals in Infection Control and Epidemiology. Adrian, I'll let you take it from here.
Thank you so much for that lovely introduction. So today I'm going to be presenting on infection prevention and control of novel multi-drug resistant organisms, including Candida auris in dialysis settings, in hopes that we will enable acceptance and safe care provision for these individuals. I know we've had a lot of reports of facilities being hesitant to accept and care for these individuals. So hopefully providing some more education and knowledge about these organisms will make you all feel a little bit more comfortable and confident in accepting and caring for these particular individuals. So novel multi-drug resistant organisms, or NMDROs, are essentially these microorganisms that make any type of treatment with antimicrobials, whether that's antifungals or antibacterials, difficult or impossible. When we're talking about novel multi-drug resistant organisms, some of the most commonly encountered NMDROs in New Jersey include Candida auris or C. auris, carbapenemase producing carbapenem resistant Enterobacterales, carbapenemase producing carbapenem resistant Pseudomonas aeruginosa, and carbapenemase producing carbapenem resistant Acinetobacter baumannii. These organisms can and do cause large but silent outbreaks in healthcare facilities, largely due to their ability to silently colonize individuals without causing any outward signs of illness. These organisms can also exhibit genes that enhance their antimicrobial resistance. And while colonization with NMDROs poses very little risk to healthy individuals, it can and does cause illness and infections in vulnerable and immunocompromised patients that can require hospitalization. So some risk factors for novel MDROs include invasive mechanical ventilation and tracheostomy, as well as basically any indwelling devices. So that could be central or peripheral lines, it could be dialysis ports, it could be indwelling urinary catheters, or any other type of indwelling device that does enter the body. Other risk factors include immunocompromising conditions and other serious underlying health conditions, as well as recent exposure to broad-spectrum antibiotics or antifungals, a documented history of colonization or active infection with other multi-drug resistant organisms. A lot of these MDROs love to travel together, so it is very frequent that we see an individual that has CRE and CRPA, or C. auris and some type of carbapenemase producing organism. Other risk factors include prolonged admissions or long-term care residence at healthcare facilities, and recent healthcare rendered in high-burden areas that are both within and outside of the United States. So within the United States, New Jersey is definitely considered a high-burden area, as is our neighbor up north in New York, as well as Chicago, Florida, and the Los Angeles County and area. And presence of multiple risk factors like those that are listed here definitely does increase an individual's risk for infection. All of these indwelling devices and openings into the body provide potential portal of entry for these organisms to enter a host immune system and evade it. So these novel multi-drug resistant organisms, as I mentioned, have the ability to colonize individuals and to cause clinical infection. But it is really important to understand the difference between clinical infection and colonization. Grayson, would you be able to control the slides? They're not advancing when clicked, or going back rather. Thank you. So colonization is occurring when an individual carries in one of these microorganisms in or on their body, but they're not being actively made ill from the presence of this organism. So they don't have any signs or symptoms of clinical infection. They could otherwise appear to be healthy. However, colonized patients do actively contribute to transmission. They can spread the organism to the environment and to other individuals, and definitely are silent drivers of transmission in healthcare settings. Unfortunately, when it comes to these specific novel multi-drug resistant organisms, individuals remain colonized indefinitely, and there's currently no decolonization method that has been demonstrated to be effective. On the other hand, infection occurs when a microorganism's presence and replication results in the individual's system interacting with the microorganism, which then triggers an immune response and causes outward signs and symptoms of a clinical infection. So that could be a wound infection, a respiratory infection, a bloodstream infection, or even a urinary tract infection. Infection can either occur after colonization or from a new introduction, but most frequently it does progress from initial colonization. It's pretty rare that you see an individual immediately jump to having a bloodstream infection with an organism. Usually it starts with transient colonization or colonization in a particular body site. And patients with novel MDROs that have clinical infections do also remain colonized indefinitely, even if their clinical infection is treated and resolved. So it's really important to know that a patient that has been treated for clinical infection is still considered to be colonized. Next slide, please. So within the novel multi-drug resistant organism grouping, we have two types of organisms, the first being bacterial and the second being fungal. And within bacterial, we have two large categories, one being carbapenem resistant organisms, or CROs, and the other being carbapenemase producing organisms, or CPOs. So carbapenem resistant organisms are bacteria that have inherent resistance to carbapenems and other beta-lactam drugs, and may also have acquired resistance to these drugs. It could be through certain modalities like efflux pumps, or it could be through genes that they acquire that furthers their resistance to beta-lactam drugs. Within the grouping of carbapenem-resistant organisms, it can be further categorized as CRE, CRPA, and CRAB based on the specific bacterial species that is identified. And then on the other hand, we have carbapenemase-producing organisms. So these are bacteria that carry genes that encode for the production of carbapenemases, which is a type of enzyme that breaks down carbapenems and other beta-lactam drugs and renders them ineffective. So these germs have the ability to produce this enzyme that makes our last line antibiotics ineffective, and they can share these resistance genes, as most of them are carried on mobile genetic elements like plasmids. So the best way to really explain carbapenemase producing organisms and how they spread their resistance is a bacterial conjugal visit. You have bacteria that connect. They are in a shared environment. They get to know each other, and they spread their resistance gene from one to the other, and then they both continue to replicate and produce this resistance gene. Within the grouping of CPOs, it can be further categorized as carbapenemase producing CRE, carbapenemase producing CRPA, and carbapenemase producing CRAB. Next slide, please. So to better visualize how these groups are related to each other, we have the larger overarching umbrella of multi-drug resistant organisms, then a subset of multi-drug resistant organisms that show either resistance to or they may be intermediate to carbapenems. Then within that group of carbapenem resistant organisms, we have carbapenemase producing organisms. So not all CROs are considered CPOs, but generally speaking, all CPOs are considered CROs. Next slide, please. So when it comes to transmission of both carbapenem resistant organisms and carbapenemase producing organisms, this occurs in healthcare settings through direct or indirect contact with either colonized or infected patients, contaminated environmental surfaces, or contaminated patient care equipment or devices. Transmission usually is person to person through healthcare worker hands or through shared medical equipment or devices that have persistent contamination, either due to physical damage or ineffective cleaning and disinfection of those items. Some potential reservoirs to consider when it comes to transmission includes both wet and dry environmental sources, depending on what the particular organism is. There are certain organisms like Pseudomonas aeruginosa that really thrive in wet environments like sinks, toilets, ice machines, hoppers, plumbing systems, basically anywhere where there's water or moisture. And other organisms can really thrive in drier environments. Candida auris can definitely persist in really dry environments, as can Acinetobacter baumannii. So they could be found in air conditioning units or even air vents. Next slide, please. So moving on to Candida auris or C. auris, this is a fungal organism. So antibiotics will do nothing for this organism. It would require antifungal treatment if it is a clinical infection. But this particular organism does have inherent antimicrobial resistance, which is one reason why it is concerning. It is considered to be primarily healthcare associated and typically affects the most vulnerable patients, like those that we previously discussed that have underlying health conditions or immunocompromising conditions, that have multiple indwelling devices and may have mechanical ventilation or tracheostomy. C. auris, unfortunately, has become increasingly common in the United States since it was first identified in New York in 2016 and very quickly jumped right across the water over to New Jersey and has spread down and across our state over into Philadelphia and across the country. We're definitely seeing spread as well. C. auris previously was very frequently misidentified as other types of yeasts, but luckily that practice has definitely improved over the years, but this is all under the assumption that the yeast is being speciated. So definitely something to keep an eye out for. And C. auris, similar to the other novel MDROs that we discussed, is capable of colonizing individuals in addition to causing a variety of clinical infections like bloodstream infections, respiratory infections, wound and urinary tract infections. Unfortunately, Candida auris does have a very high estimated attributable mortality rate, ranging anywhere from 40 to 60%, primarily due to the patient population that it tends to impact. It tends to affect those that have multiple serious underlying comorbidities or conditions that also contribute to mortality. Next slide, please. So there's a couple of factors that make C. auris particularly challenging. There is no known incubation period for C. auris, so there's no magical time period between exposure and development of the organism or development of symptoms. It also colonizes individuals indefinitely, and there's currently no effective decolonization methods known. So once an individual has any history of C. auris, they should always be treated as positive for C. auris. It does require transmission-based precautions to be implemented for all healthcare admissions and visits following identification, and we'll talk a little bit about the specific precautions that are recommended for dialysis settings, but typically gown and glove is what is recommended for these individuals. And something else that makes it particularly challenging is its environmentally hardy nature. So it is resistant to many common cleaning and disinfectant products and readily contaminates medical equipment and environmental surfaces. So cleaning and disinfection practices are really key to preventing any transmission of this organism. It can survive on surfaces for up to weeks if it is not effectively cleaned and disinfected with a product that is effective against C. auris, and those can be found on EPA's List P. Products that have bleach ingredients are effective against C. auris, but there's also many non-bleach based products that are effective against C. auris as well. Next slide, please. So similar to what we saw with CROs and CPOs, the transmission of C. auris in healthcare settings again occurs through direct or indirect contact with either patients that are colonized or infected, contaminated environmental surfaces, and contaminated patient care equipment or devices. And transmission again is usually person to person on the hands of healthcare personnel or on contaminated shared equipment or devices. Next slide, please. So diving a little bit further into C. auris, specifically in New Jersey, as I mentioned, we have a very notable burden of C. auris in New Jersey, since we were basically right across the water from ground zero in the United States. As of January 1st of this year, we have 1,668 total cases identified in New Jersey. A little over 1,000 are surveillance cases, so those represent colonization and not cases that are actively infected, and that is more than 2/3 of our case count, so that's definitely something notable. We have a little under 500 confirmed clinical cases, with almost 100 of those being cases that initially started as colonized and progressed to clinical infection. And we have an additional 22 probable clinical cases stemming from the first identification of C. auris in our state back in 2016. Next slide, thank you. So we've definitely experienced a really notable increase of C. auris over time. It has really been an exponential increase every year since 2018. And really the COVID-19 pandemic has significantly contributed to the increase and spread of C. auris within healthcare facilities. There was a number of factors that came into play during that pandemic, such as reuse of PPE and shortages of PPE, staffing shortages, increases of patients that are vulnerable and considered to be high risk for C. auris, as there were a lot more patients on ventilators. And as a result, we have definitely seen quite the increase every year in the number of cases identified. Next slide, please. So in addition to our very significant burden of C. auris positive individuals in New Jersey, we also have a lot of individuals positive for C. auris that need dialysis. We looked at our case report forms for a little over 1,000 C. auris case patients that were identified and forms received as of June 1st of last year. And approximately 200 or almost 20% of those case report forms indicated that the C. auris positive case patient needed dialysis at the time of C. auris identification. And really, as we continue to identify more and more C. auris cases in New Jersey, the need for dialysis among this specific patient population is only going to increase. As a result, reluctance and refusal to accept C. auris patients in outpatient dialysis settings does prevent these individuals from being discharged from higher acuity settings, which does result in longer hospital admissions, and longer hospital admissions equates to increased risk of acquiring other healthcare-associated infections. Next slide, please. So in terms of infection prevention and control measures for C. auris in dialysis facilities, really what would be recommended is what is already being practiced. So that is really good news for everyone here. We definitely recommend adherence to standard precautions and adherence to the infection control practices that are routinely recommended and carried out for the care of all hemodialysis patients, as well as informing and educating any and all appropriate personnel about the presence of a patient with C. auris. We do recommend the use of alcohol-based hand sanitizers as the preferred method for hand hygiene when they're not visibly soiled, or if you're not caring for a patient that has diarrhea. Alcohol-based hand sanitizer tends to have higher adherence rates, so it does make it the preferred option when not visibly soiled. We also recommend performing hand hygiene in between all glove changes, and specifically the use of gown and gloves when caring for patients with C. auris or touching items at the dialysis station, and critically making sure that any gown and gloves are changed after use on a patient with C. auris or other novel MDRO. Next slide, please. So in terms of minimizing exposure to other patients, there's certain considerations that you can take into account, but these aren't required. So that's important to know. It's definitely helpful to minimize potential exposure to other patients, but none of these are absolutely necessary. So you can consider dialyzing the C. auris positive patient at a station that has as few adjacent stations as possible, so either on the end or the corner of a unit. You could also consider dialyzing the C. auris patient last, so on the last shift of the day, if and when that is possible. If you have an abundance of private rooms that you're able to use, that can also be considered for dialyzing a C. auris positive patient. But it's really important to note that private rooms are not a requirement for dialyzing C. auris positive patients. We definitely recommend thoroughly cleaning and disinfecting the dialysis station, so chairs, side tables, machines, between patients, by using products that are approved for use against C. auris. So that could be any bleach-based cleaning product or anything else from EPA's List P. Properly cleaning and disinfecting reusable equipment brought to the dialysis station after each use, and informing any facilities where a C. auris case patient is subsequently being transferred about the patient's C. auris status. We do have a really helpful novel MDRO transfer sheet you can access by using the QR code here, that can be used to very clearly communicate an individual's positive MDRO status during all transfers to other facilities. So really the bottom line here is that dialysis facilities are really well equipped to handle C. auris because the standard practices that are already being carried out in this setting effectively prevents and minimizes transmission within this setting. So the use of gown and gloves during care, the use of bleach-based cleaning products, and adherence to standard precautions all are really effective at preventing transmission of C. auris within dialysis settings. And in terms of infection prevention control measures for CROs and CPOs, the same IPC recommendations for C. auris also apply for these organisms. And these MDROs are spread in the same manner, so they do share the same methods for preventing transmission within healthcare settings. Really, the only difference for CPOs and CROs is that you do not need to use a product from EPA's List P, but bleach-based products typically are effective against most, if not all, CROs and CPOs. But you should always refer to the manufacturer's instructions for use to determine effectiveness against target organisms and equipment that it is recommended or not recommended for use on. And that is all I have for you today. I do have our C. auris website linked here, as well as the email address for our HAI-AR EPI team over at the Communicable Disease Service. So if you have any questions now or later on, feel free to shoot us an email, and we're happy to help however we can. Thank you.
Well, thanks, Adrian. Wow, that was a lot of information, right? I don't know about you guys, but I took a whole lot of notes. Hi, I am Naomi. I am an infection preventionist for DaVita, and part of my territory to cover is the great state of New Jersey. Shout out to the friends that I see on the call. Glad to see you. So I'm going to just take 10 minutes or so, and I'm going to talk about DaVita's process for how we are successfully caring for these patients. But while I do, if you would do me a favor, I would love it if your clinic has treated a Candida auris in the past, or is currently, or has the ability to do so. Would you do me a favor? Send us a note in chat and just let us know where you are so we can get a good feel of the folks that are already doing this. So Grayson, let's do it. And like I said, I've only got a couple of slides. So if you want to give me the next one, we're going to talk through what we do. All right. So DaVita, and I'm sure with all other dialysis providers, Candida auris came on our radar, I would say about 2018. And, you know, and it was so troubling and disturbing. And we, like everybody else, read all of the upcoming information that was on the CDC, and it seemed like a fluid information. And our first instinct, probably everybody's first instinct, was these patients, because of this scary fungal organism, they must be subacute and they really shouldn't be treated in an outpatient dialysis setting. It doesn't seem safe. That was our viewpoint. But the more we learned and the more we researched, we understood that this could be safely done in a dialysis session. So you'll notice on the bottom, and I only have 3 slides, I have given you the CDC website. So DaVita, when we were coming up with our process to safely treat these patients, we used 100% CDC resources. So I've given the links down there. I don't know if you just do a CDC search, you can find them, but we didn't have to come up with our own protocols or processes. The CDC website is really outstanding with this. But what we identified early on is there were kind of 3 components to it. We had to have notification that the patient was coming, we had to have education, and then we needed to monitor. So we have admissions, we've instructed them to flag patients that are going to be admitted to us that have Candida auris, but we did identify that that's not a fail-safe. So best practice is when a patient is going to be admitted to the clinic, somebody needs to be reading the admission paperwork to look for Candida auris. So we, as you can imagine, when we first made the decision that this could be safely done, we had a whole lot of pushback. And unsurprisingly, the pushback came from medical directors because they didn't want to introduce this into their clinics. They wanted to keep their patient population safe. Really, it should be done in a hospital setting. So we had to get buy-in from our medical directors. So our step on a company-wide level was to provide physician education on how this can be done safely. And as Adrian was talking about, this is similar to how we're treating MDROs. And the fact is, we already do this. We already use contact precautions or transmission-based precautions. We already do the hand hygiene. We already do PPE. We already do disinfection. This is muscle memory for our folks. So we provided a whole lot of education to our physicians on the front end. And also, if there is a facility that they're trying to admit a Candida auris patient and the physician it doesn't have buy-in. We actually do peer-to-peer discussions. We have an amazing group medical director who could, if needed, reach out to that physician and talk them through how this is done safely to get the medical director comfortable. So the first step, we need to get the buy-in from the physician, notify the clinic. And then the second step that we do before we ever admit a patient with Candida auris, they all hear the sound of my voice. I do live WebEx education with the facility administrator, the clinical coordinator, the clinical team. Only takes about 10 minutes, and I talk them through the simple processes. It's transmission-based precautions, it's PPE, and it's disinfection. And I make sure that everybody's comfortable and they get the education before the patient ever walks into the door. And then the third step is we've got to monitor and make sure that they're still doing it. It's not enough for me to provide information and education to a team. There has to be regular observations and audits and continued education. My cadence is quarterly. When I have a clinic that has a Candida auris patient, I reach out quarterly. They hear the sound of my voice again. It doesn't take long, 5 minutes, but I talk them through transmission-based precautions, PPE, and disinfection process. So if you want to give me the next slide. So let's talk about how we actually do this. So I talked a little bit about buy-in, and I'm sure that some of you have experienced this, but I've had an instance, not in New Jersey, but in another state, that they had agreed to take a patient, but when the clinical coordinator saw that it was Candida auris, they wanted to decline the admission because she had done a Google search and scared herself just enough that she was afraid that she was going to expose her patient. So part of the information that I do in educating the patient, educating the team, is their first question to me is, am I safe? Second question, are my patients safe? The answer is yes. The team is safe because I talk them through the PPE, and it's very important that they understand it. Remember that Adrian said that this is spread by contaminated surfaces and on the hands of healthcare workers. So this isn't airborne. This isn't like TB, which is a scary thing. We are the ones who spread it. So that being said, if we do our due diligence and our precautions, it's not going to be spread. So the first of all, I talk to the team about personal protective equipment, PPE. That gown that they're wearing is dedicated for the use of that patient. So if I have Mrs. Smith, who's been diagnosed with Candida auris, and I've got her at a station and I've got my PPE gown, I only wear that gown to care for that patient. So it is dedicated PPE. If I've got a blood pressure cuff and a stethoscope, since those can be cleaned and used again, it's dedicated for that patient. So I talk about PPE, dedicated PPE, and how to don and doff, mean putting it on, taking it off safely to make sure that we're not spreading the organism by a contaminated gown or contaminated gloves. And then I talk specifically about hand hygiene. So here's the thing about hand hygiene, is that just because it's being done doesn't necessarily mean that it's being done correctly. So if you're doing an observation and you see a nurse or a technician put a spot of hand sanitizer on their palm, scrub it together 3 times for luck, and then reach for the gloves, they did not perform hand hygiene, did they? It should be enough hand sanitizer on their hand that it lasts for 15 seconds. It is a 15-second motion, and they are scrubbing as if they are washing with soap and water. So palms of the hand, fingers, and between the fingers, the back of the hands, the tips of the fingers. It's a 15-second process. So those hands are clean before they reach for the gloves. And I remind them that gloves are not infection control. They don't prevent infections. All they do is they're protecting my hands, and whatever is on my hands, they're protecting the surface. But if I touch a contaminated surface and I don't take that glove off and I touch another surface, guess what? We're spreading it. So when I look for hand hygiene, I look specifically, are they doing it well enough, long enough, and do they recognize when that glove is contaminated? They've got to take it off, genuine hand sanitizer, hand hygiene for 15 seconds, and then re-glove. And then we talk about how to minimize exposure to the other patient. So I have them identify a station where this patient, that's where they're going to live, that's where they're going to treat. So at the end of the row, in a corner, away from foot traffic. So that's the station that we've identified, and that's always going to be where the patient goes. And Adrian said, you know, it should be the last treatment of the day, and it really should, and that's in a perfect world. So I do encourage them that once the station is used for that patient, if possible, that station remains empty until the next day. And then most of my presentation is how to get rid of it, how to disinfect so that whatever organisms are there, it's a fungus, and like Adrian said, it's hard to kill, it's very hardy. We got to make sure that we don't spread the joy. So this is muscle memory for our PCTs and nurses. They know how to do it, but you should still do education and observation. And it's not for a gotcha, it's not. But if you don't know it, you can't fix it. And you need to watch them disinfect to make sure that they're doing it properly. So disinfection, there are 3 components to it. It's the solution that you're using. So in this case, the product that's going to kill Candida auris. It's the friction of your scrub, and it's the dry time. So first of all, make sure that they've got the right product, EPA approved to kill Candida auris. One of my links on the bottom is the list to that EPA List P that gives you the list of organisms of the list of products that kill this organism. Once you get that canister or whatever it is, label it for patient use, and it stays to that patient. So there's your product, there's your first component. Your second one is the friction of the scrub, and this is where you're going to watch. They should lay that chair back, open it up, scrub with friction and enthusiasm, leave the chair open and let it dry. The machine, top, sides, the bottom, the IV pull, the blood pressure cuff, the chase wall, the chase counter, all of it is scrubbed. It's friction of the scrub. It's not enough to just do a general wipe. So scrub with friction and enthusiasm, let it air dry. Nobody should be coming behind with a dry bleach wipe to dry the surfaces. Let it all air dry. If possible, don't use the station again until the next day. That's really just best practice. So if you want to give me my next slide. And here is my last one. So here's what we do. So we are treating patients with Candida auris. We've been doing it probably about 5 years now, and we are doing it successfully. And like I said, we didn't come up with the protocol. We used all of the CDC resources. We didn't reinvent the wheel. And we based our protocol based on what the CDC has. But the first and primary, again, Adrian's presentation was outstanding, and she called out the fact that this is transmitted by healthcare workers' hands. So first and foremost is adherence to hand hygiene, but that means, is it being done correctly? Are those gloves, when they're contaminated, they come off, using authentic hand hygiene for 15 seconds before they re-glove? So that's a big focus of ours as part of the transmission-based precautions. And then we make sure that we've got the right product on hand that has approval to kill the Candida auris. So Adrian mentioned bleach-based products, but this does not mean our routine 1 to 100 bleach. That is not enough to do it. So make sure you go on and you do research and find a product that will kill it. Also make sure, and Adrian actually gave you a QR code for it, that when you've got this patient that you're going to transfer them somewhere else, you must notify the receiving facility that this patient is colonized with Candida auris, so that they can make their own preparation. And lastly, you're going to provide regular education and oversight, because the fact is that these precautions are in place in definitely. Once this patient is colonized, we assume they are always colonized. So these precautions don't go away. So like I said, my cadence is quarterly because I want to make sure not only does everybody remember it, but maybe I've got some float nurses, maybe I've got some new PCTs or nurses, and I've got to make sure that they're doing it correctly. So we've been doing it safely. And I encourage you, if you haven't adopted a protocol or haven't looked into it yet, I encourage you to do your research on the CDC site. And if you consider this along the lines of MRSA or VRE that we've been treating for years, this is just another organism that we can do safely. As long as we're doing the right precautions, PPE and disinfection, it's done safely. It's something that we are, we're vigilant about, but it's not anything scary. So I appreciate Network 3. Thank you for giving Davida the opportunity to share. I hope it's helpful. And for folks on the call, Network 3 and the New Jersey Department of Health are wonderful resources. So reach out to them if you've got questions. And again, if you have questions on any of this, put them into chat, and our friend Grayson afterwards, if we've got time, we're going to go through the questions in chat, and hopefully we get you some answers. So now I'm going to pass it over to Jessica, who's going to talk to you about the ICAR process.
Thanks, Naomi. So for those of you who may have tuned in late, my name is Jessica Auris. I'm a nurse infection preventionist with the New Jersey Department of Health, and I lead the infection control assessment and response unit here at the department. Now, NJDOH is a very large agency of the state. Next slide, please. So I thought it would be helpful if I take some time to go through the organization. So both Adrian and I work within the Public Health Service. This is separate and distinct from health systems. And so those are individuals who are responsible for your annual surveys. They come in to make sure you're compliant with CMS's conditions of participation, New Jersey Administrative Code. They're responsible for inspections, and then also the certificate of need and licensing. So they allow you to set up shop and operate as a licensed dialysis clinic in New Jersey. Within the Public Health Service, the two offices that you most likely interface with as a hemodialysis provider is the Office of Local Public Health, and that's who oversees the local health department in your area. And then next slide or enter, the Division of Epidemiology, Environmental, and Occupational Health, which is where the Communicable Disease Service is located. Next slide. So I ask that you please bear with me as I try to break this down a bit further. So the Communicable Disease Service has 4 distinct programs, as you can see on your slide. But the one that I'm really going to focus in on today was just newly formed. We're coming up on our birthday. It is the Infection Control, Healthcare, and Environmental EPI program, which we refer to as ICHE for short. Next slide, please. So the ICHE program is comprised of 4 units. Next slide. We have the Healthcare Associated Infections and Antimicrobial Resistant Unit. That's where Adrian is located. They do both prevention and response work. So some examples include coordinating screening, such as point prevalence surveys. This is also where the Antimicrobial Stewardship Recognition Program is located. Some of you may be familiar with that. We also have the ICAR unit, which I will expand on in the coming slides. We have our water systems and environmental infection control. This unit primarily responds to Legionella and other waterborne pathogens in both the community and healthcare settings. And then finally, our health education and outreach unit. This is where Project First Line content sits, and much of our other content is created with this lovely group of health educators. Next slide, please. So the ICAR unit's primary focus is providing infection control, assessment, and response consultations. We generalize our services into 2 main focuses: prevention, where we focus on preventing healthcare associated infections to prevent any transmission events, and essentially quality improvement goals for the dialysis provider or clinic. And then on the other side, we have response-driven partnerships where we focus more on containing an organism, typically SARS-CoV-2. It could be in conjunction with the healthcare associated infections and AR unit to respond to a novel or targeted pathogen such as C. auris. Each of these consultations is an attempt to bring together the facility leadership and facility staff with representatives from local and state public health. So as you can see, I did upload or include an image of our draft tool. Some of you may have been partners in the past to work with our unit in the form of an ICAR assessment, as we referred to it. We're currently in the process of revising the assessment tool. It currently has 11 modules unique for hemodialysis. We are actively seeking facilities to partner with us in the hemodialysis setting. We do ask that you consider booking us out as late as April or May, no earlier than then, so that we can partner to pilot and implement this new tool. If for some reason there is a need and you are requesting additional support, our services are free and we are happy to come out and use the current CDC version of the infection control assessment tool available. Next slide, please. So part of the ICAR consultations focus on competency-based training resources. Naomi talked about the importance of properly applying product to your hands when performing hand hygiene and safely removing or doffing PPE. One activity that we facilitate on site and bring resources to leave with you all is referred to as Caught Red-Handed. And so this is a quick and dirty, fun, maybe 3-minute top, just-in-time exercise you can do with staff to assess competency for the hand washing technique, application of alcohol-based hand rub, and then safe removal of contaminated gloves. Next slide, please. Part of this process, we also provide a fluorescent marking gel when we come out to do an ICAR consultation. These are really helpful to assess the effectiveness of cleaning. That can be on mobile medical equipment, shared supplies, the dialysis bay in and of itself. And you essentially apply it to the environment. The individual will go in and clean whatever product or area needs to be cleaned. And then you go back and to assess if the fluorescent marking product was effectively removed by use of a UV light. We typically do this with the turn of a station. So after a patient's been dialyzed, you could go in and apply this marker. It would be cleaned or turned over as usual. And then you would go back collectively as a group just to assess if the current process and technique is effective at removing soil from the environment. Next slide, please. So there's a lot of information sharing and activities that occur during the ICAR consultation. In an effort not to overwhelm the facility, we do provide important just-in-time feedback based on the observations and consultation, but then we also follow up with a written report to give any additional resources or feedback that the facility needs to further enhance quality and care delivery in their facility related to infection prevention. And then facilities who partner with the ICAR unit in the form of a prevention-focused consultation, we do provide a certificate of appreciation to recognize your efforts in promoting infection prevention and control and patient and healthcare personnel safety within your facility. Next slide, please. Those who do partner with the ICAR unit will also receive a follow-up questionnaire. So we're actively soliciting feedback in both our process and materials. So here are just a few quotes from some of our work. Also, our 4.8 Google rating. So we do actively monitor our data and are doing quality improvement internally as well. Next slide, please. And just as I wrap up this information, I wanted to highlight both federal infection prevention and control resources. I know Adrian and Naomi included links along the slide deck. I imagine most of you are very familiar with CDC resources, but for those who may be newer to the industry or just as a reminder, there are various tools, there's webinars, materials available, and also the Making Dialysis Safer for Patients Coalition. And you can enroll in that if you're not currently a member, either as a facility or organization or as just a provider. You can also participate. Next slide, please. And then last but not least, I wanted to share some key New Jersey specific resources from our Health Education and Outreach Unit. They've created some fun interactive resources. We have the escape room, which is really popular. There is a toolkit where you can facilitate this independently among your own group or staff in your building. You can also request that one of our health educators come out and facilitate this for free. And the goal is to defeat Captain Clutterbug. We recently partnered with the Health Education Unit to create a doffing technique video. So it shows how to the 2 methods of safely removing gloves. And then we've compiled a 1-page handout, which we will also share with Grayson and Annabelle to disseminate on resources relevant to this presentation and how to safely deliver care to individuals who rely on dialysis, who are also colonized or infected with Candida auris. Next slide, please. And so I just wanted to thank you all for your attention. I know there was a lot of information shared this afternoon. I did include a QR code, so if you have your smartphone handy, you can point that at the screen. That should take you directly to the ICAR booking site. So if you could save that, bookmark it when you're ready, or if you're interested, you can go ahead and self-schedule when you would like myself and my colleagues from the ICAR unit to come out for a non-punitive free ICAR assessment. But again, as a reminder, in an effort to really use the new tool and experience our new approach, we're encouraging facilities to delay until spring 2024. And in the meantime, the ICAR unit also strives to be a resource for infection prevention and control. So in addition to the expertise available at your facility, feel free to reach out with any questions. Back to you, Grayson. Thank you.
Thank you. And it looks like we have one question in the chat, and I will stop sharing this so we can see everyone. I'm not sure, it was during your presentation, Jessica, so I don't know if you want to answer this one or if you can read it, but I'll read it out loud if you want to answer it. What frequency should curtains be changed out, as curtains are not generally disinfected as part of the station, although they may have been contaminated, especially in foresight of regularly taking care of C. auris patients?
So I'm happy to chime in. I'm not sure, Naomi, if you're interested in sharing your...
No, I'm all set. It's all you.
Okay. So basically, if you look at CDC guidelines, things such as curtains, and I know the hemodialysis guidelines are very dated and just recently updated, but we do have the 2017 HCPAC guidelines for safer care delivery in all healthcare settings, which would include hemodialysis. There's basically an onus back on the facility to define a frequency. You'll find that CDC guidelines typically say routine, and so there should be a risk assessment and a policy or expectation internally as to how frequently those should be changed. Now, as far as treating someone, dialyzing someone who's colonized with C. auris, this should not be unique. You've likely cared for people who require isolation, maybe someone who has scabies or bed bugs. You would want to refer to your existing policies to make sure your expectations match across the board when you're dialyzing someone who requires contact precautions. That will help reduce any confusion among staff. And then the only nuance would be ensuring you're using the appropriate product, a product that has a kill claim for the organism you're targeting. So I can share some guidelines and get back to you for reference, or there may be some examples out there. And then I'll defer to any other panelists if they would like to expand on that.
I'd also recommend to just check the manufacturer's guidelines, because sometimes the manufacturer has a cadence as well.
Okay, thank you both. Does anyone else have any questions? If you do, you can go ahead and put them in the chat or the Q&A now, and then we can have our presenters answer them. We have about 6 minutes left.
This is Jessica. Just kind of looking at the Q&A, I wanted to also offer up knowing the material of the curtains you have. I know there's differences if you're an inpatient acute dialysis or outpatient in the bays, and your physical layout is very dependent on how you're going to respond. If you have laundering, if you have textile curtains that require laundering, Naomi brought up a very excellent point. Those are only good for, you would want to refer to your manufacturer's instructions on their life cycle. A lot of the disinfectants we use in the healthcare setting are intended for non-porous hard surfaces. So it's worth as an infection preventionist, you should be doing your due diligence to review the products in your facility and the materials they need to be used on, the availability of soft surface disinfectants. If you do have textile curtains, to implement that added measure and potentially disrupt or prevent a transmission event of an organism in your facility.
Thank you, Jessica. Is there any more questions in the chat or the Q&A? I'll give it a minute in case anyone's typing. There's another question in the chat. Do you want me to read it out loud for the presenters, or can you read that? And who wants to answer that?
Yeah, Grayson, it's Naomi, and I can jump in and use that. So the question is, I'm aware of existing protocols that state not to use the Hep B isolation rooms and repurpose them as rooms to treat other infectious diseases. So this is an important call out. So I'm not sure who put it in, but much appreciated. So here's the thing, is that even though you can use an isolation room, it's not needed. And if you've got a Hep B patient already in the isolation room, you can't use it for anything else, only Hep B, right? So that's where it's important to make sure that you sequester is kind of the wrong word, but put the patient at the end of a row somewhere in the corner, but they don't need to go in an isolation room. So if some of the pushback is we can't take a Candida auris patient because we don't have an available isolation room, they're not treated in isolation. They're treated separately using additional precautions, but within general population. So thank you to my anonymous friend who pointed that out. Well done.
And there's another question that says, should we have a separate room for mdros?
Yeah, it's me again. Sorry, taking over the Q&A. Nope. Again, we just use additional precautions. They're kept right in general population, but you are going to use transmission-based precautions for those folks. So you're going to identify who they are, dedicated PPE, dedicated supplies, right? But they can stay right there. In many instances, right in their own chair. We're going to just make sure that we don't spread it to other folks. So good question.
And since there's only 2 minutes left, I will go ahead and do the closing. But if anyone has any additional questions, if you received the email for the invite for this webinar, you can always send in more questions and we can send them to the presenters if you need to. But thank you to everyone who was able to join us for today's webinar. The slides and a recording of today's sharing call will be available on our website at qualityinsights.org/QIRN3 later this week or early next week. Thank you to our guests for joining us today, as well as all of our attendees, and we hope you can join us again next time.